Good evening, everyone. Today's topic is rheumatology, and the faculty we have here is Dr. Abhash Jain, sir. He's a consultant physician and specialist. So you may take over. Thank you.
Okay. So we will starting today with the final and the third class for rheumatology. So we have few theory slides left with us. Then we will be doing few MCQs. So coming on to dactylitis. So dactylitis describes the inflammation of a digit, that is finger or toe. A sausage-shaped digit is classical description of dactylitis. So what are the causes that may cause dactylitis? Spondyloarthropathies such as psoriatic and reactive arthritis, and it could also be due to sickle cell disease. Other rare causes include tuberculosis, sarcoidosis, and syphilis. So coming on to juvenile idiopathic arthritis, few rheumatological illness which are common in children. So we'll discuss them. Referred to the older term, juvenile chronic arthritis describe arthritis occurring in someone who is less than 16 years old that lasts for more than 3 months. Pauci-articular juvenile idiopathic arthritis refers to cases where 4 or less joints are affected. It accounts for around 60% cases of juvenile idiopathic arthritis. So features of pauci-articular JIA, joint pain and swelling, usually medium-sized joints such as knee, ankle, elbows are involved and patient usually limp. ANA may be positive in JIA associated with anterior uveitis. So next is Perthes disease. So it is a disease of the children. Perthes disease is a disease of children and it is a degenerative condition affecting the hip joint of the children. Typically between the ages of 4 and 8 years. It is due to avascular necrosis of the femoral head. Perthes disease is 5 times more common in boys. Around 10% of the cases are bilateral. Features include hip pain. Patient develops progressively over a few weeks, usually the limp, stiffness, and reduced range of hip movement. X-ray shows early changes including widening of the joint space. Later changes include decreased femoral head size and flattening. Next is Henoch-Schönlein purpura. So Henoch-Schönlein purpura is a IgA-mediated small vessel vasculitis involving mainly the blood vessels of the skin, GI tract, kidney, and the joints. So they have manifestation in the skin, some GI manifestation like loose motions, some features suggestive of nephritis, and then joint pain can occur. So 90% of the cases of HSP occur in children aged 2 to 10 years, but can occur in any age group. More common in children. So it is the most common cause of vasculitis affecting the kidneys, typically commoner in males, may follow an infectious agent. It can present 1 to 3 days following infection of a IgA secreting mucous membrane. Commonly following pharyngitis, but can occur following infection of the gastrointestinal tract, bladder, or breast. An important risk factor in adult is chronic alcohol intake if HSP occurs, associated with H. pylori, hepatitis B, and malignancy. So the HSP is characterized by tetrad of purpura, abdominal pain, arthritis, and renal involvement. Patients with patient has hematuria and proteinuria. Patients with proteinuria have a worse prognosis than patients with hematuria alone. Palpable purpuric rash with localized edema over buttocks and extensor surfaces of the arms and legs due to cutaneous vasculitis. So there will be a palpable purpura. Abdominal pain is due to the vasculitis of the gut, which may be severe in some cases, leading to bloody diarrhea. Polyarthritis is a common symptom. Feature of IgA nephropathy may occur, hematuria and renal failure may develop. So diagnosis is on skin biopsy and immunofluorescence demonstrate leukocytoclastic vasculitis with IgA deposition, meaning lots of white blood cells in the skin around small blood vessels, which is pathognomic for HSP. So you have to remember these points. Immunofluorescence studies will reveal IgA deposit within the blood vessels. Treatment analgesia for arthralgia. Treatment of nephropathy is generally supportive only. All patients with hypertension and proteinuria greater than 1 gram per day should be started on an angiotensin converting enzyme inhibitor, which may control the BP and proteinuria. Once the BP has been controlled, patient should have a renal biopsy, and if they show changes of a crescentic glomerulonephritis, then an immunosuppression regime similar to that used in renal vasculitis should be started, probably with high dose steroid in the first instance, plus minus cyclophosphamide. Steroids plus minus cyclophosphamide. There is an inconsistent evidence for the use of steroids and immunosuppressants. Management of HSP in adults often involves the use of immunomodulatory or immunosuppressive regimes, in contrast to children where the majority of the cases resolve spontaneously. So usually children only supportive treatment is required. Coming to prognosis, usually excellent prognosis. HSP is a self-limiting condition, especially in children without the renal involvement. There is often a more complicated course in adults, and 50% of the patient who presents with renal involvement develop renal insufficiency. Around one third of the patient have a relapse. So these are typical symptoms and signs of HSP: abdominal pain, nausea, vomiting, bloody diarrhea, joint inflammation and pain. Raised reddish purple spots or bruised area mainly on the buttocks, legs and feet. In some individuals, spot may appear on the body, trunk, arms or hands. So next is Kawasaki's disease, which is another type of vasculitis which is seen in children. So Kawasaki's disease is a type of vasculitis which is predominantly seen in children. While Kawasaki disease is uncommon, it is important to recognize as it may cause potentially serious complication including coronary artery aneurysm. So otherwise it is rare. Features are high-grade fever which lasts for more than 5 days. Fever is characteristically resistant to antipyretics. Other features in Kawasaki's disease: conjunctival injection, bright red and cracked lips, strawberry tongue, cervical lymphadenopathy, red palms of the hand and soles of the feet, which may later peel. So strawberry tongue, you have to remember it, cervical lymphadenopathy. Kawasaki's disease is a clinical diagnosis as there is no specific diagnostic test. How will you manage? So high dose aspirin will be given. Kawasaki's disease is one of the few conditions for the use of aspirin in children. Due to the risk of Ray's syndrome, aspirin is normally contraindicated in children. Then you will give intravenous immunoglobulins, combination therapy with IV immunoglobulins and aspirin during the acute phase of Kawasaki's disease produces a more marked anti-inflammatory effect and reduction in coronary artery abnormalities than does aspirin alone. Echocardiogram rather than angiography is used as the initial screening test for coronary artery aneurysm. The complication is coronary artery aneurysm, 25% of the cases. So in brief, Kawasaki's disease is a lymphomucocutaneous disease. 5 characteristics of the disease, 4 out of 5 for diagnosis. Fever, cervical lymphadenopathy, usually unilateral, erythema and edema of palms and soles with desquamation of the skin, non-purulent bilateral conjunctivitis, strawberry tongue, and treatment is IV immunoglobulin and aspirin. So this is a brief. At least 4 out of 5 should be present. Okay, coming to SAPHO syndrome. So SAPHO is an acronym for synovitis, acne, pustulosis, hyperostosis, and osteitis. It is characterized by osteosclerotic bone lesions, sterile osteomyelitis, and variety of skin lesions. So the full form is synovitis, acne, pustulosis, hyperostosis, and osteitis. Synovitis may be present rarely and associated with erosions. Acne may be severe, conglobate, or fulminance and recur with new bony involvement. Pustulosis, palmoplantar pustulosis, occurs in approximately 50% of the patient. Other skin lesions may include psoriasis, hidradenitis suppurative, acne, and rarely Sweet syndrome. So hyperostosis is increase in bone substance, and osteitis is inflammation of the bone. The bony lesions typically involve the acromioclavicular and sternoclavicular joints. Other sites include anterior chest wall, sternum, clavicle, pubic symphysis, spine, and mandible. These lesions are visualized on the technetium bone scan or MRI. The cause of Sapho syndrome is unknown. Investigation: skin lesions are characterized by neutrophilic pseudoabscess. Bone biopsy can reveal sterile osteomyelitis. Diagnosis should be suspected when there is an association of rheumatic pain with pustular skin disease. So, any patient is having rheumatic pain like joint pain, stiffness, and pustular skin disease. So, suspect Sapho there. There is no specific treatment. Some cases remit spontaneously. Typical treatment can be used for arthritic symptoms, NSAIDs and disease-modifying anti-rheumatic agents. Isotretinoin and acitretin can be used to treat the skin disease. In more severe cases, corticosteroid, calcitonin, biphosphonate, and TNF inhibitors. Okay, so let's do few questions. A 25-year-old female was started on minocycline for the treatment of acne. 7 days later, she presented with fever, myalgia, arthralgia, and fixed erythematous rash over the malar eminence that spared the nasolabial fold. Which autoantibody test would confirm the diagnosis? Anti-dsDNA, anti-stone, anti-Jo1, anti-RNP, anti-SCL70. Okay, so anyone can answer if you know. If you don't know, I'll wait for 15-20 seconds, then we'll discuss. Okay. So the correct answer is anti-stone. Okay. Because the features of drug-induced lupus, list of drugs causing lupus, autoantibody association, and rheumatological conditions. So this patient has developed drug-induced lupus as a result of minocycline therapy. The typical rash and what he has: fever, myalgia, and arthralgia. And the typical rash over the malar eminence that spared the nasolabial fold. So this is a syndrome of positive anti-nuclear antibody that appears during therapy with medication and biological agents. It has less female predilection than SLE and rarely involves central nervous system and kidneys. So SLE involves CNS and kidneys, but drug-induced lupus does not. It is rarely associated with anti-dsDNA and is commonly almost 100% associated with antibodies to anti-stone. So anti-stone positive, then it is drug-induced lupus. Most specific test. So about 50 drugs has been listed, but the important are penicillamine, procainamide, phenytoin, carbamazepine, isoniazid, and minocycline, AC inhibitor, beta blockers, hydralazine, propyl thyrosol, hydrochlorothiazide, interferon, and TNF inhibitor. Out of these, most important which you have to remember is phenytoin, carbamazepine, isoniazid, and minocycline. So anti-dsDNA antibody is almost exclusive for SLE but rarely positive in drug-induced lupus. Anti-Jo1 is associated with acute onset of poly or dermatomyositis. Anti-RNP is present in syndromes that have overlap features of several rheumatic syndromes. Anti-SCL70 is associated with 40% cases of diffuse systemic sclerosis. Next question. A 70-year-old man complains of pain and stiffness in both his shoulders. He has lost 1 stone in the last 8 weeks and complains of feeling lethargic with loss of appetite. Investigation revealed a very high ESR, normocytic normochromic anemia, and positive rheumatoid factor. Which one of the following is the most likely diagnosis? Polyarthritis nodosa, polymyalgia rheumatica, polymyositis, rheumatoid arthritis, and SLE. So, elderly male, 70 years, pain and stiffness in shoulder, weight loss is there, lethargy, ESR is markedly raised, anemic and positive RA factor.
Polymyalgia rheumatica.
Yes, doctor, correct. So it is polymyalgia rheumatica. So it is an inflammatory disease which typically presents with pain and stiffness of the shoulder and pelvic girdle muscle. It can have either an acute or subacute onset and associated with systemic inflammatory response and therefore constitutional symptoms such as fever, anorexia, weight loss, and malaise. So RA factor can be positive in many conditions. The course of the disease is unpredictable and 30% of the patients also have giant cell arthritis. So there is an association between polymyalgia rheumatica and giant cell arthritis. The cause is unknown, although Study shows a cyclical incidence led to the theories regarding an infectious trigger. However, an autoimmune nature is there. All of the below are thought to predispose to development of SLE except exogenous estrogen administration, HLA-DR3, congenital deficiency of C2, HLA-B8, and breastfeeding. Let's see. So it's breastfeeding. Exogenous estrogen administration, HLA-DR3 and D8 and congenital deficiency of C2 are thought to predispose to the development of C2. Whereas breastfeeding is thought to be protective. So breastfeeding is protective for SLE. Other are the predisposing factors.